Why doesn't everybody stand up and just stretch for a minute? If you've been sitting for an hour, maybe stand up and just stretch for a minute, please. Okay, thank you. You ready? One more? I think we're halfway through. You're going to have 3 more after me, so it's kind of hard on my butt sitting there all day, so we have to stretch. I want to thank you. Thank you for having me here. Actually, my wife asked me if I would come with her and present as well. So I'm very grateful to be here. One of the reasons I'm grateful to be here is I feel like I'm coming home. And this is the first time I have spoken at a professional conference on colon hydrotherapy. And I've had a license for 40 years to practice this work in the state of Florida. I built my own machine. I've trained dozens and dozens of people across the United States, especially when I moved to Colorado and I had a school there. I used a gravity machine, and then I built my own gravity machine and practiced in Miami for some time, and then turned my practice over to my sister. So my sister and I right now are actually writing a book on metabolic syndrome. So I'm very interested in this topic and have maintained an interest for over 40 years, although my wife does most of the clinical practice now in our spa back in Florida. So thank you. So I'm coming home. This is the first time I've actually been able to do a professional presentation to my people, my tribe. 40 years, it's amazing. You also heard in my resume that I practice and teach craniosacral therapy. That's mainly what I teach right now. And we were asked in the hallway by a cranial practitioner, when would you use craniosacral therapy in a treatment for colon hydrotherapy? Well, the answer to that is the beginning, middle, and end. And I said, if you have someone that comes in that's very sympathetically driven, then you would want to calm them down before introducing water, if you had a technique to do that. My wife will frequently do foot massage sometimes in order just to settle the person if they've really had a rough day already before introducing water. So you can use it in the middle of a session. You know, in the middle of a session sometimes, when all of a sudden it gets very calm and you turn the outflow and things are flowing out and there's a still point in the room. You notice that? So sometimes you get that still point, and it's during that still point that you can just relax and maybe switch to another modality that would help their nervous system go into an even deeper relaxation. So I like to say, in terms of clinical practice, to wait for the still point in the middle of a session. And that's when you can really back off, put the water on outflow, and really let the person settle on the table. And then use another adjunctive therapy if you have that at your disposal. Or just leave them alone. The autonomic nervous system loves to self-regulate. It can self-regulate on its own. We've already given that system a lot of stimulation. That system loves stillness and it loves slowness. And if we can provide both of those, that system will self-regulate. That is the idea. They have to self-regulate. We're simply providing a container and a holding environment for that to happen. Does that make sense? Okay. Now, in my presentation here, you've all read that it's about the embryology of the large intestine. And I really need to provide context for that. First of all, there's a lot of emerging literature that most of the metabolic problems that our clients face and what the human body faces now in our culture come about from prenatal development. So I'm assuming there are not many people in this room that have had a course in human embryology. Is anybody familiar with human embryology? You've taken a little bit of work? That's great. It's a huge field, and I think it's a very important field that we begin to know what was going on in prenatal development that seems to be the source of so many problems that show up later in your 20s, 30s, and 40s. That was the literature 10 or 15 years ago. These problems are now showing up right after birth. Babies within 1 to 2 months after birth can be clinically obese, become clinically obese through no fault of their own, but through a stress that came into the family environment, into the mother's environment, through the placenta, and into the fetal environment, and changes the whole metabolism of the embryo and the fetus. So it's very important that we have some connection with that early time of life, that pre-verbal time of life. So I want to be able to show you some images right in the middle of this presentation of the embryo, but I'd also like to make sure that we orient it clinically. I don't want to just present information because I've studied this for so long. I want to get it into your hands. So we've had every presentation has been great. I want to thank all the presenters, and each have given us a gift. And if there's a gift that I would like to give you, it's where to put your hands, how to put your hands in a certain location, and especially how to affect the autonomic nervous system. Almost every single presenter has mentioned the word autonomic nervous system. So here we will go into it a little bit deeper, okay? So the clinical orientation is going to be important. I want to start off the presentation showing you the large intestine. I was trying to count how many times we saw the large intestine so far today in images. I lost count after about 40. So you're going to see the large intestine a few more times, but that's our business. And this is our tribe. And we are the people that are doing this work, and it's amazing. So what I'd like to do is to start off with a research report. It's called a functional colonic obstruction. Well, we're familiar with colonic obstructions, or we should be, but this talks about the obstruction that's occurring at Cannon's Point. Now, Cannon's Point is located really close to the splenic flexure. I'll move over a little bit. And it's really close to the splenic flexure. And it's at that point where Cannon's Point is located. If you're in Germany, it's called Cannon-Bauer Point. Okay? So what is the importance of that? So here we have the location right around there of Cannon's Point. And we see here in this next image that at that point there's a complete switchover in the cardiovascular system. You have a different arterial supply that is going here to the ascending and transverse colon, and it's coming from this artery right here called the superior mesenteric artery. And that's going to be important that you have just a little bit of this language before we look at the embryology. Then, what we cannot see here, or very little, is that we have the inferior mesenteric artery that comes up right here, and it's giving you the arterial supply to the descending colon and to the rectum. We'll take a look at this later on in the presentation a little bit. Okay. Point. 2 cardiovascular supplies to the large intestine. Where do they overlap? They overlap at Cannon's Point. This is going to be important because the embryological development of the gut That's a critical point right there that differentiates your gut from the pelvis and the organs of the pelvis. That from an embryonic point of view include the descending colon and rectum. Okay? Now, we'll also see in this presentation that there's another overlap that's happening right here, and that overlap is with the vagus nerve. If you've studied the autonomic nervous system, many of you know, and you saw it on many slides today, that the vagus nerve comes down and it's what's responsible for a large part of peristalsis. The vagus nerve is mainly sensory, but about 25% of it is motor. So it has some motor fibers that go to the lungs, that constrict the lungs, and interestingly enough, the other fibers that are motor go to the large intestine and contribute to peristalsis. So we want to have a very healthy, happy vagus nerve because the vagus nerve is so widely researched right now. It's looked at in several segments of the human body. There's a lot of research on the vagus nerve and the face called the social nervous system. There's a huge amount of research that I'm sure you're familiar with on the vagus nerve and the heart and the pulmonary system and the aorta. So we know that the vagus nerve slows the heart down, right? That's kind of physiology 101. Very important to know that. But it is also tied into what is called heart rate variability. Every single heartbeat that you have, and you've had thousands of them since you sat down here this morning, every single one of those is different. And they need to be different. Because if they're the same, you're heading for a cardiac problem, or you're at risk for a cardiac problem. So heart rate variability is also controlled through what is called vagal tone. So we want to have good vagal tone to have good heart rate variability, which means a slow heart rate. Well, what does that mean? Lower stress. So my wife talked about this morning is the lower stress. That's the mechanics of it, okay? Now, it's very important that we lead a stress-free life. Isn't that correct? Well, how do you do that? So there's a lot of antidotes, and what I'm recommending now, especially if you live in the United States, and fortunately you don't live there right now, but it's going to be good when we come back because it'll be after our election, is what are called HCLs. There's a lot of literature about raising vagal tone through having feel-good experiences and having 10 to 15 feel-good experiences during the day where you can just pause, take a breath, slow down. But an HCL is very, very important, and it's called helpless, convulsive laughter. When was the last time you had a laugh so hard that you bent over double and almost hit your head on your knees, or the last time you laughed so hard you threw your arms up in the air? Think about it. I'm just suggesting that if you want to improve bowel movements, improve heart rate variability, and improve sociability through your face, that you begin having periodic, helpless, convulsive laughter episodes. And I'm saying that with a smile on my face, and I'm telling you I'm very serious because there's a lot of literature that supports this, okay? And there's also laughing yoga. How many of you have heard of laughing yoga? So here's Cannon's point if we were to look at a radiograph, and you can see the constriction that's happening right there. And when you have a constriction at this layer, or this level right here, you can bet that it's likely that something happened prenatally. And this is a very important area here to work. I was laying in bed this morning and finally realized that I probably had over 1,000 colonics in my life. And every time the therapist got near Cannon's point, that's when I had my biggest release. Because my mother was chronically constipated all of her adult life. And it probably came through to me some way or another, whatever that mechanism is, prenatally. So, first clinical point, when you're doing your massage work, whatever or however you're contacting, make sure that you get around this area, because you're going to be affecting the overlap of the cardiovascular system and the overlap of the vagus system. Because what happens if the vagus ends here, what happens here? It's picked up by the parasympathetic outflow coming from the sacrum. So the parasympathetic system comes up from the sacrum, through the rectum, through the pelvic viscera as well, but we're specifically focusing on the large intestine, and all the way up to here. So this is where your sacrum kind of meets your hypothalamus, so to speak, or your brainstem. Your vagus nerve originates in the brainstem. So brainstem meets pelvis right here at Cannon's Point. And we'll look at that more thoroughly. Here's another image of Cannon's Point right here. And you can see how the blockage builds up here. There's a narrow constriction here before it gets to the splenic flexure. So one thing I just highly recommend, if you only have one takeaway in terms of manual therapy, because that's what I teach the most, is to find a way to work Cannon's Point through circular massage, however you might come into relationship with that point. And I think you'll see a shift or a change. They don't have to have a blockage at that point. We're talking about regulating the parasympathetic nervous system. We're talking about regulating the cardiovascular system and the sympathetic system, which is actually hooked into the cardiovascular. When I say cardiovascular, that also means sympathetic. Because every single blood capillary, every single artery is highly, highly innervated by the sympathetic system. That's where we see the balance. Sympathetic, cardiovascular, vagus, okay, on the other end. So now we have a little bit of time for some embryology. This was originally an animation that I pulled off the internet, and I've used it for probably over 10 years. And we were not able to get the animation rolling or working, but we took still shots. So I'm going to have to talk you through motion. If you go onto the internet and you put in Valerie O'Loughlin's name, she's at the University of Indiana, or just put in your Google search, embryology, animation, GI system, you might find this, and it was a free download for me 10 years ago. We're going to start looking at a 5-week-old embryo, and that's about 6 or 7 millimeters. And when it comes to the large intestine, you're going to be looking at something that's about the size of a lentil in its development. So there's a tremendous amount of epigenetic activity going on in terms of its growth and its relationship to all the other structures around it. And it's easily influenced, or the term is imprinted, by negative stress. It's also, the newer term is called biological embedding of prenatal stress. And we see a lot of people who have embedded stress within that large intestine of theirs. So here we have a look at the basic divisions here. And we can see right here the gut tube as it comes down the middle of the embryo. The stomach is just a pouch. And then we have the middle of the intestines right here, and then the bottom right here. Here we have the superior mesenteric artery. And to me, that looks like the tree of life. Again, in scaling, we're looking at something the size of a lentil in terms of its structure, and it's fully formed, and it's functioning, it's working. There is liquid going through there. There is an exercising that is happening through the tube of the intestine. All adult function is pre-exercised in the human embryo. And that's a very important principle, especially when it comes to peristalsis. And let's see if we can get a sense of that. So the gut tube in the embryo is divided into three regions: the foregut, the midgut, and the hindgut. Now, the foregut, as you can see here, comprises the face. So you have the upper end of your GI tube. We think it's maybe the lips, but that's not right. The upper end of the GI tube forms your teeth. These are cells that are in that is called endoderm, the endodermal tube. You have cells that are forming the muscles of mastication, that are forming the bone structure. So you have a hard, muscular upper end of the GI tube. That is why we continually hear and see dietetics and nutritional advice being offered, because yes, you have to have people chew their food. You're working the upper end of the GI system, okay? The muscles and the bones comprise an integral part, and the neurological reflexes going back and forth of that tube. It's very, very important. So I mentioned earlier, look at the hindgut right there. If we were to take and go forward in time, that would be Cannon's point right there. Do you see the cutoff right here between the midgut and the hindgut is right about there? And guess what that artery is? The inferior mesenteric artery. So right there is where the beginning of that inferior mesenteric artery begins to feed the descending colon, the rectum, and other organs within the pelvic floor. So you can see that this is the celiac trunk, and that comprises the three major arteries of your intestines. About 75% of the outflow of blood coming through the abdominal aorta is coming through those three arteries into your organs. That's a lot of blood, and it requires a lot of sympathetic control. So in my work now, what I'm doing is I'm teaching the therapist to make contact with the superior mesenteric, inferior, and celiac trunk, because you can have a very positive effect in the balancing of the sympathetic and parasympathetic just by touching those arteries. So you don't have to do a full massage. Sometimes you can just touch those arteries and get very, very good results. So I just talked about this and named those arteries for you. So celiac trunk goes to the stomach. About 30% of the outflow from the celiac trunk goes to the liver. Where does the rest of the blood, if the abdominal aorta and the celiac trunk are only providing 25 to 30% of blood to the liver, where is the liver getting its other 70 or 75% of its blood from? The portal vein, which is coming from the large intestine and the small intestine and some of the organs. So it's a huge outflow from the portal vein. So here's where we have this pre-exercising of the adult function of peristalsis. So you have what's called the primary intestinal loop. What's happening now in the embryo is that you have a strong growth factor starting at about 6 weeks post-fertilization. And there's not a lot of room because it's a closed space and it's only open to the yolk sac. So it starts to grow really rapidly and twists and spirals. So let's see. And that twist and that spiral creates a cranial limb and a caudal limb. So a part of that large intestine that's actually facing up towards the head and the cranium, and a part that's facing down. And you can see right here that that intestine now is going to start to grow, and it's going to, by definition, herniate out into the yolk sac. So a closed space, there's not a lot of space, so when you have something that's growing rapidly, it's going to go to where it's easier to go in terms of growth, and that's going to be through a narrow tube called the vitelline duct right here into the yolk sac. And that's also, you see the umbilical cord, they should actually be differentiated right here. That's one incorrect thing with this particular slide. Okay, so here we have at the beginning of the 6th week, the abdominal organs are growing faster than the abdominal cavity itself, which forces the primary intestinal loop to herniate through the umbilicus into the umbilical cord. This herniation continues for about 2 to 3 weeks, and here's the key for peristalsis. As this herniation occurs, the loop undergoes a 90-degree counterclockwise rotation around the superior mesenteric artery. The superior mesenteric artery is a key to the whole large intestinal growth pattern, okay? And later in development, then, the inferior mesenteric artery takes over that descending. But the initial development is through, and it looks like, I always compare it to the tree of life. It looks like this giant tree that's growing right out. And it's the superior mesenteric artery. And towards the end of this presentation, I'll show you where it's located exactly in the adult abdomen, so you can palpate and find it. That should be an interesting way to end, if people poking around their bellies. At least it's not after lunch. Okay, so here you see the twisting that's occurring. So you get this counterclockwise rotation that's occurring, and it's occurring out and through fast growth, all right? This herniation continues. By the 8th week, the cranial limb is now located on the right side of the body, and the caudal limb is located on the left side of the body. During the 8th through the 10th weeks of development, the primary intestinal loop continues to grow and elongate. So you have this continual coiling that's happening. And on the very inside of that loop, any of the cells on the inside of that loop are being squeezed, and anytime you squeeze cells like that, you create what are called zones of stillness, or in biology it's called quiescent cells. So in development, we have a particular type of cell. It's actually located all throughout the body. Anytime you have a tube that bends in the embryo and fetus, the inner curvature has cells that get squeezed. That decreases its metabolic activity. And those are called quiescent cells. It turns out that quiescent cells, or cells that are dynamically still, are regulators of growth and development. And through resonance, that's one of the reasons that at our school we teach people, the therapists, once you learn the equipment and once you learn how to manage the therapeutic relationship, which could take 30 or 40 years, but within that learning and development, there needs to be space for quiet. There needs to be the recognition of zones of quiet that occur either in the room or within the client. You can always tell, or almost always tell, when a client's getting still. Leave them alone at that point, please. Their autonomic nervous system is rebalancing itself. And there's a lot of good literature on that in terms of how the sympathetics work. And once there's that quieting time, they get to rebalance at a deeper neurological level and a more restorative level in terms of the cardiovascular and autonomic connection to the intestines themselves. Okay, so during the 8th through the 10th weeks, we see now at the 10th week this cecal bud that forms. the caudal limb also develops on the enlarged cecal bud, which will form the cecum. So here we can see this twisting, this arrow right here representing this twisting, in the very beginning of the cecal bud in this area right here. So that first pouch differentiating the location of the small intestine to the large intestine is occurring right at the end of the 10th week. The 10th week, depending on who you read and what you read, is the transition zone between the embryonic period and the fetal period, okay? So most everything is in place at the end of the embryonic period, and then once you get into the fetal period, it just expands and grows from there. Technically, that's what embryology books say, but when you look at the biology of it, I don't think as a human being our bodies are complete until we die because of the growth and development that it continues. Now, here's where we have that principle of the pre-exercising of adult function and peristalsis. You have an intestinal loop that's going out, that's herniating out counterclockwise, but over time the body wall is going to expand, and that means that that intestine now can rotate back in. So you get the opposite twisting back in. So there's your peristalsis. The basic, it's called morphology. The basic morphological movement of peristalsis is forwards and backwards. It's like a washing machine. I remember when I first learned this, and I was just washing my clothes, and I said, it's a washing machine because it moves back and forth, okay? And this is very important in terms of secondary and tertiary digestion that's occurring in the large intestine. But once you get to Cannon-Bauer point, then you get into more of a dehydration chamber. And we saw a slide this morning that showed the different function of the microbiome. And then we just saw a presentation that it's a different pH. I hope that's making sense to you now, not only from the prenatal development, but how it goes through with the development of the vascular system and autonomics, right at that point, and how the function changes of the large intestine. The function changes, along with the various structures that are attached to it. Okay, so now we have this looping back in. As the loop is retracting, it undergoes an additional 180 degrees counterclockwise rotation about the superior mesenteric artery. Once again, if you have a second takeaway, and I'm going to show you where this superior mesenteric artery is. If you have a second takeaway in terms of your clinical practice, the first one, cannon point. See if you can massage that point to get that transition zone for the entire autonomic and cardiovascular system regulated, contained, working, functioning better, okay? Second takeaway, learn where that superior mesenteric artery is located, and I'll show you that in a couple minutes. And then all you have to do is feel the artery. All you have to do, you don't even have to massage the artery. You put your fingers on the artery, you will affect the endothelium of the artery. The majority of research going on right now in terms of the structure and function of the cardiovascular system has to do with the endothelium. The endothelium, which is the inner lining of the artery, okay, that is made primarily of quiescent cells, interestingly enough. So we just mentioned quiescence before, the necessity for stillness. When you have metabolic disorders, those endothelial cells, both the endothelial cells in your large intestine and the endothelial cells in your arteries, lose their stillness and they change their shape. They are the primary signaling system between the blood, the nutrition that's coming from the blood that goes through the artery to the end organs. That signaling system gets disrupted. and different size molecules start going through the artery, okay, start going through the intestinal wall. And these are very, very damaging molecules, as you've read. And my book will be out next year with my sister, and then hopefully we'll get it translated into Spanish. So just putting a finger on the artery can change the endothelium if you stay in a quiet place. I've trained hundreds and hundreds of people to do this work, to touch these arteries, and we're seeing incredible results. Why are we seeing those results? We're seeing it because the change in the endothelium, number one, and number two, the change in the sympathetic nervous system. Because you've got two types of sympathetic nerves that are hooking up to those arteries, all the way down to the level of the capillary beds. So very, very important to be able to change that tone in order to get the vagus nerve working peristalsis better, okay? In order to get the vagus nerve working the heart better, and in order to get the vagus nerve helping you be more socially related. When you are more socially related, you're more empathetic. When you're more empathetic, you're more compassionate. When you're more compassionate, you're more kind. You can instinctually work from a base of kindness and knowing how to make contact with that other person. Now, that's a big trip to lay on the vagus nerve. But it's a very important nerve. These dynamics of empathy, compassion, and kindness are instinctual. There's the literature on compassion right now is outrageous. The scientific literature on compassion. And so the ability to slow down and become still is one method of waking up the instinct for compassion. Compassion is an instinct to care. We all care, okay? And so we're in the business of caring for other people, and we can promote and wake up that instinct even more. And especially when we have our fingers on the blood. Somebody mentioned in here the microbiome and the huge percentage of cells in the microbiome that far outnumber human cells in the body. Do you know what the majority of human cells are in the human body? 83% of what are considered to be human cells. So 83% of our humanity are blood cells. 83% of what makes us human is located in the cardiovascular system, okay? At a biological level, we have the spiritual level, we have the psychological level, all of this is related, okay? So the cranial limb retracts first because the cecal bud on the caudal limb acts like a knot in a rope, preventing the caudal limb from moving first. So interesting metaphor. The cecum then is a knot in a rope. And there was a mention this morning of working the ileocecal valve. And that's exactly what happens. The ileocecal valve has circular muscle fibers in it. It can go into a spasm. If it can go into a spasm, it gets tied up into a knot. So Kathy, my wife, was suggesting that just in that angle coming into relationship with the ileocecal valve, just a light massage will normalize the tone if those circular muscle fibers in that valve are in spasm, then when they get knotted up. And how many times have we heard that expression? It's in English. I don't know what the expression would be in Spanish, but I feel like my intestines are tied up in knots, okay? And we see that in the embryological development, the counterclockwise motion, back and forth, this motion, okay? And it's a growth motion, okay? And it's tied into the cardiovascular system and tied into the autonomic system and very related to how peristalsis functions. Okay, then we see here the cecum right here, the appendix, and now we get a really sense here of the remaining parts of the colon coming down to the rectum and anus. So This extension down here then is going to be fed by the inferior mesenteric artery, as I mentioned. Good. By the 11th week, the transverse colon now rests in the front of the duodenum. So we can see this transverse colon in through here, and there's our ascending colon, although it's got a very interesting route that it's taking right here. And then look how big that descending colon is. So all of this growth is way out of proportion embryonically. And by having that type of differential rates of growth, you're going to stimulate differential rates of growth of the autonomic system, of the vascular supply. So by the way in which it grows and the size to which it grows is the degree to which it gets innervated. It's beautiful because the blood will always go and track these tubes and everything in the body. It goes right along, the cells of the blood go right along with it. It's a beautiful, beautiful system, the way it's set up. And all of the nerve cells, this is your neural tube back here, if we were to extend it all the way around back through there, all the way from the back here are where the cells of the autonomic nervous system are coming. So you have cells right here that are growing forward that then follow the tracks of the cardiovascular system, and they follow the tracks as they go into the intestine. So the movement is from posterior to anterior with the autonomic system. Okay, and then we're getting towards the end of this piece here. Initially, the cecum and a very short ascending colon rest underneath the liver. And so we know this is also a very good area to work because the large intestine actually has ligaments that attach to the liver and to the fascial capsule of the liver. So here we see why that is important and why that large intestine is suspended from the liver and connected to the liver, the kidneys, and so forth. During the fetal period, the vitelline duct regresses and disappears. So we can see now that this yolk sac is going to disappear. We'll still have an umbilical vein and artery, and now we start to get into the normal or regular positioning during the fetal period. Although you don't have a lot of functioning going on within the large intestine, some meconium is making its way through. So the large intestine does practice during pregnancy its function of moving through, and it's filled with fluid as well, so it's functioning at that level. And once the final position of the intestines is attained, the ascending and descending colon becomes secondary retroperitoneal. So they go behind the peritoneal wall, and it's a process by which their mesenteries fuse to the posterior abdominal wall. And that's just the fascial bag that holds your intestines, okay? So you have to imagine that it's a big sandwich bag, and it's holding your intestine, and it gets fused to the posterior abdominal wall. So these last images are showing you how the large intestine gets anchored to the organs and to the liver and so forth, and the diaphragm, and then to the posterior abdominal wall, all of which can be manipulated with your hands depending on your skill level. Now, these last few slides, oh good, we have some time. Here's a really good image right here. This is the inferior mesenteric artery, right in through here, coming down. There's the sigmoid colon, and there's the rectum, right in through there. Beautiful image of that part of it. This particular, wait a minute, I had another one. There. This was the superior mesenteric artery, and here's the celiac trunk. So here's and that's actually the renal artery right there going to the kidney. In this presentation, I've only discussed the celiac trunk, superior mesenteric artery, and inferior mesenteric artery. But here you can see the superior mesenteric artery. Look how big that is. Remember in the embryo, it was like the tree of life. I liken it to that. And here we can see how pervasive it is, because now it has to feed all of the small intestine, and then the ascending colon and part of the transverse colon over to Cannon's point. Okay, so we're back to Cannon's point. There's the inferior mesenteric artery. Now here, I want to show you the sympathetic plexuses, because you have the sympathetic plexi that are coming off of the spinal cord, and they correspond to the celiac plexus, the superior mesenteric artery, and the inferior mesenteric artery. So like I said, cardiovascular system, sympathetic system, that's where you get that hookup. And these areas right here between the xiphoid process and your umbilicus right there, this is where those sympathetic nerves come closest to the surface before they cover those arteries, okay? There's like a nexus right there. You can put your fingers, what I tell my students is I take my fingers like I'm playing a piano, and I just put it on a line between the xiphoid process and the umbilicus, and I just wait. You're going to sense a lot of high tone in a lot of people. It could be from a hiatal hernia, or it could be just tension in general. All you have to do is let your fingers wait for that tissue to melt, and that will allow the sympathetic system to soften. So if you have somebody that's sympathetically activated, you can put your fingers there. You can put the palm of your hand there, because you're right over all three in that area. And it's very, very simple. And by affecting the tone of the sympathetics right there, you're affecting the tone of the blood supply throughout the entire small and large intestine. You're normalizing blood supply. This is Netter. I had to have this redrawn a little bit. Here's Cannon's point here. Can you see where all of these, this looks like a map to a train station. Kind of like Milano Centrale, or maybe it's like the one here in Barcelona. So at any rate, you have the vagus nerve coming all the way here, but then from here, you've got the blue is the parasympathetic from the sacrum coming all the way up to Cannon's point right here. So again, you could have someone with persistent low back pain, and you could have someone with had they fallen on their coccyx, and you can have large intestine dysfunction because it's going to affect the sacrum. So you have to have some mobility also in the sacrum and spine. So again, it's a holistic way of thinking about treatment in terms of the large intestine. This is just a map that just came out in Germany showing you how that hookup is happening right up here to Cannon's point. So here's the overlap point right here between the vagus nerve and the parasympathetic system coming from the sacrum right here and lumbar spine. And here we have, once again, the inferior mesenteric artery for the large intestine, the small intestine, and then the large intestine, and then the inferior mesenteric artery. See that trail coming right down there and right in through there. And I think I have one more. Yes. Go back.
Yes, please. Thank you.
This was just published in Germany a couple of months ago. Okay, this is the map that I give my students. This was published in Jean-Pierre Barral's book called Visceral Vascular Manipulations. This is the map then that I use to teach students. So here's our umbilicus right here. And here's number 6, the inferior mesenteric artery is 1 finger width above the umbilicus, just 1 finger. And right here, the superior mesenteric artery is 3 finger widths. So you just take the client's 3 fingers in and around the umbilicus and 3 fingers up. Right there on the midline is the superior mesenteric artery. But stay close to the surface, because if you go too deep, you're on the abdominal aorta. And I wouldn't recommend working with the abdominal aorta first. So this is the location of the inferior and superior. Just stay light. I take my hands and I just overlap them, and I very gently put them in that direction. And I just visualize the embryology, because I know that this is the way the embryo developed, and you'll start feeling the intestines go into a curvature. Don't allow your hands to just be static, but just let them float. I say let your hands be buoyant. Let your hands be buoyant, and then you'll feel the turning of the intestines very slowly. Okay? So, that is the end of my presentation. I wanted to give you 3 takeaways, 4, and this is the 3rd and the 4th. The location of the inferior mesenteric artery and the location of the superior mesenteric artery for your palpation. Where are they located? They're located right by the sympathetic plexus. So you can stay non-specific on those 3 plexi right on the surface between xiphoid and umbilicus, or you can get specific. You just have to be careful to not over-focus, and that can compress. You have to just maintain a perceptual field that's really wide. I sometimes will look out the window when I'm working and then bring my attention back, just to allow a sense of openness and relaxation for the client. Okay. So that's the end of my presentation, but I wanted to give you a couple minutes for questions if there are any, because that was a lot of information. And I do have a colonic joke in terms of raising vagal tone. So if you have no questions, then I'll have to tell a joke.
Hi, I'm Amanda from Aragon. At the beginning of your presentation, you spoke about the diagram that is most used of the large intestine, which everybody knows. But in reality, when you look at X-ray, the colon is not that shape. And I'm just wondering how that influences these points that you're mentioning today, whether they can move around because the colon is irregular.
One of my teachers said that a map is not the territory. And so what that means is I start knowing that could be the age of the patient, because with the age of the patient, you get a lot of ptosis, the organs relocating. So I take my hands and I start where I think it might be, and then I do a very slow circular motion until I think I can find it. If I can't find it, then I have to palpate where I think the large intestine might be and orient to that. But usually these arteries are going to stay within a pretty close distance. But I would say give yourself up to anywhere from 2 to 5 centimeters. And that is a lot of experience, because students will come in and that's the first thing they'll say, I couldn't feel it on the first 2 clients, but then I could feel it on the 3rd. And then you have to give people permission to explore where it might be. But within a map, I call it the new GPS, okay? You've got a GPS where these are by making a circular motion. The abdomen doesn't like to be poked. It likes circular motions. It's the best way also to distribute heat in the intestine. So I like to make a circular motion primarily. If I can't find the arteries in the abdomen because you've got clients with obesity, what I do with my obese clients is I put both my hands as broadly as possible, because visceral fat has its own cardiovascular system. And so I feel the entire vascular system of the obesity, and I start feeling that system breathe, okay, and move, and feel the blood move. And that way I can resonate with the arterial system through that. I call obesity the second placenta. Other questions? Yes.
About the craniosacral.
Wait, please, wait.
Thank you. You talked about craniosacral techniques in the beginning. What kind would you suggest? Or do you just mean in general just the way that you work with holding this wide perception? Or do you have any particular visceral techniques that you could explain shortly?
Well, I think we live in the day and age where there's just a lot of integration across different modalities. And when I practice craniosacral therapy, I have just found over the years that I have a couple of favorite things that could really calm someone down. So they're like my favorite techniques. And this area right here on the atlanto-occipital joint space, the AO, what the osteopaths call the gateway to the cranium, well, this is where all the nerves are coming through in the back right here. So I tend to just put my fingers and support that tissue right there until it softens. And coincidentally, the vertebral artery is going through that tissue as well, and when it softens, you'll feel the vertebral artery. That's when I know I'm getting better blood flow to the brain, because I want to get better blood flow to the brain as well, and this work here will support it. Working on the feet, depending on how your room is configured and your table is configured, working on the feet might be easier than working closer to the head. So if I work on the feet, I tend to hold the anterior tibial artery, which is a very easy artery to feel. Right on the, well, if you know where your big toe is, all you have to know is where your big toe is. Okay, let's say this is this is a big toe right here, which is typical because my middle toe here is longer. So I guess I have the same hand. So you just look at the tendon of the big toe, and it's lateral, and it's in a gully, and it's anywhere from the ankle all the way down towards the big toe, and you can anywhere in there just put your fingers and you'll feel the artery. And the closer you get to the big toe, you're on liver meridian, so you're having a very good effect on the liver. I've seen that over and over again with the acupuncturists that come in and train with me. They love that particular technique because it stimulates and normalizes liver tone. Thank you.